Hello and welcome back to Expert Perspectives from the 20th Annual NOCR meeting again in Las Vegas, Nevada. So we've talked to Ruth O'Regan about breast cancer, and now Dr. Axel Grothe from the Mayo Clinic Rochester is here to talk, obviously, about GI malignancy. So Axel, welcome to Expert Perspectives.
Thank you, Jim.
Well, thanks for coming in. So today was interesting. The session was marred a little bit by the absence of Jordan Berlin, who was ill, but you and David Ilson covered for him very well. And Jordan's first assignment was to talk about a clinical situation in pancreatic cancer, whether to use FOLFIRINOX or gemcitabine or the nab-paclitaxel gemcitabine combination. And when the FOLFIRINOX data was first presented several years ago, it was sort of astounding. I mean, we had seen so many gemcitabine plus or minus drug X trials where the gemcitabine arm invariably had a median duration of survival of 6 months, and gemcitabine and drug X also had a median duration of survival of 6 months. And so FOLFIRINOX comes along and it's got a median survival of almost a year, and that was just amazing. Toxicity, you know, which we would have all expected having played with FOLFIRI and FOLFOX over the years. But so tell us about this situation, how you're using FOLFIRINOX, how the regimen has been modified to make it more tolerable, what sort of responses and durability of responses you're seeing, and what you feel is the role of the nab-paclitaxel gemcitabine combination.
Yeah. So I actually remember several years ago at one of our NOCR meetings here in Las Vegas, there was a debate between me and Dan Haller about should we abandon gemcitabine as a backbone for drug development in pancreas cancer. And of course, you take a position in a debate, but I think every one of us was kind of clear we need to go beyond gemcitabine. But we didn't do it. It was the French group that did the study. Right. And I think for a long time, we actually made a mistake in how we approach pancreas cancer. We thought, you know, this is a bad tumor, patients have very poor outcome, so let's not do any harm, and let's give a little bit of gemcitabine, which we know is very tolerable, but really not very effective. So I think the right answer was given in the FOLFIRINOX study. Aggressive tumors need aggressive therapy, so FOLFIRINOX clearly, hands down, beat gemcitabine and set a new standard of care in clinical practice. Now, FOLFIRINOX, as you said, you know, is associated with more toxicities. Not every patient with pancreas cancer is a candidate for FOLFIRINOX. But when we asked a show of hands who has used FOLFIRINOX, almost the whole room had used FOLFIRINOX for the treatment of pancreas cancer. And these are community oncologists, so it had made inroads into our standard of care. Now, the French investigators and the way how we use FOLFIRINOX at Mayo Clinic, we have both abandoned bolus 5-FU, the bolus 5-FU component.
Just like everybody has in FOLFOX.
Exactly, like in FOLFOX in the palliative setting, which really decreases one of the major toxicities, which is neutropenia, which eventually predisposes patients to less infection, which is an issue, of course, with more aggressive therapy. So we have data with FOLFIRINOX now, investigator-assessed response rates over 30%. I personally have seen patients with long-lasting complete responses in a situation of liver metastasis, even peritoneal disease. We're actually using FOLFIRINOX now in clinical trials, but also in clinical practice in a kind of a borderline resectable setting where you need to pull the tumor off the SMA to make it resectable, perhaps add radiation therapy. That's a whole area of research right now based on the fact that we now have a chemotherapy regimen that actually can induce responses, something that had really not happened before.
Absolutely.
Now, when the nab-paclitaxel gemcitabine trial came around, I mean, which randomized patients to gem versus gem plus nab-paclitaxel, it's clearly better. I mean, showed better outcomes for patients. Response rate went up, progression-free survival went up, and overall survival with the addition of nab-paclitaxel. And then we tried, one of the discussions that Jordan's talk today was meant to lead was, so what about cross-trial comparison? What do we do for a patient? Should we now go for the approved gemcitabine nab-paclitaxel combination, or should we use FOLFIRINOX? And invariably, we need to compare between clinical trials, inclusion, exclusion criteria, what's the patient population, with small differences between these study groups and study populations. I think the evidence suggests, that FOLFIRINOX is stronger, more toxic, but definitely more effective than nab-paclitaxel plus gemcitabine. So for clinical practice in an otherwise healthy patient with limited comorbidities, I think we've agreed that FOLFIRINOX, modified FOLFIRINOX, non-bolus 5-FU, is probably the way to go in first-line therapy.
David mentioned that he was using nab-paclitaxel gem as a second-line regimen.
We're using that too, and it's interesting. Yeah. A lot of questions actually came up about, what about third line? So we have FOLFIRINOX, nab-paclitaxel, gemcitabine. So what about third-line therapy? And I think that's a remarkable development in the last 2-3 years, that we're now talking about third-line therapies for pancreas cancer, because you only give third-line therapy. The question only comes up if you think patients are in still good shape, that they could tolerate
so if you have a patient who responds to FOLFIRINOX, then progresses and gets nab-paclitaxel gem, responds, and then progresses, do you ever go back to FOLFIRINOX?
I've done that. I've actually reutilized chemotherapy agents like what we've done in colorectal cancer, for instance, for a long time, in gastric cancer, doing it more and more. We're turning pancreas cancer into a more chemosensitive disease, also in our mindset, how to approach patients. And I have patients who are, where, pancreas cancer patients are normally very sick from their disease. Even with low volume disease, they can be very sick. But if you have active treatment options to push the cancer back, make patients better, they can actually be in good performance status for quite some time now.
So one of the other really important and interesting talks during the GI session today was David Ilsen kind of reviewed where things stand with novel targets and novel agents. And of course, although we have FOLFIRINOX and we have nab-paclitaxel gem for pancreatic cancer, we're still missing an oncologic driver that we can target with a tyrosine kinase inhibitor or a monoclonal antibody or whatever. We need to know more about what drives pancreatic cancer, and tell us about David's presentation and what you took away from that.
Yeah, I mean, David went kind of on a whirlwind tour through all of GI malignancies and all the potential biologic targets and drug development and agents in drug development right now. And there are certain common patterns, like the c-MET HGF cascade that we are investigating, at least with interesting data so far in gastroesophageal cancers. There are ongoing studies in colorectal cancer, not so many studies in pancreas cancer, in particular when we now follow up on pancreas cancer before. It's a very complicated tumor in terms of the molecular pattern. We know that angiogenesis inhibitors don't work because it's not a very vascular rich tumor. So all the VEGF inhibitors, which we've tested elsewhere, really have shown no benefit at all. So in terms of the usual suspects of drug development in GI malignancy, which David covered, we're still honing in on VEGF angiogenesis inhibitors with interesting new data in gastroesophageal cancer, gastric cancer with ramucirumab, a drug that has 2 positive phase 3 trials, right, in second-line therapy, which will very likely lead to FDA approval. Actually, I'm already counting on using this drug as part of my treatment options. It even has single-agent data, in second-line therapy in gastric cancer, and it has combination data with paclitaxel. So that's a drug that definitely will make it into our portfolio. They have a trial, ramucirumab is also being tested in HCC, could be an interesting agent. It's being tested in colorectal cancer, which kind of competes with the aflibercept and bevacizumab beyond progression for market share in this crowded field of angiogenesis
But
inhibitors.
Targeting VEGFR2 rather than
Correct.
VEGF.
Yeah, and having at least from what we've seen so far, an excellent toxicity profile. I mean, in fact, the REGARD study, which was the single-agent ramucirumab versus best supportive care placebo study, showed more side effects for placebo than for ramucirumab, which shows, these are just cancer-related kind of side effects that we see, fatigue, etc., which was improved with ramucirumab. So the drug has an excellent toxicity profile. So that's not the limiting factor once we use the drug.
Very good. So anything else that looks like an interesting target developing? You mentioned c-Met and the rilotumumab, which targets the hepatocyte growth factor, as opposed to onartuzumab, which targets the receptor itself, and
other kinase inhibitors. Yeah. So we're blocking this HGF c-Met system on the ligand, receptor, and tyrosine kinase receptor level. And I think the critical issue for all these c-Met or MET inhibitors will be patient selection. I think there's still a debate on whether immunohistochemistry overexpression of protein is the right way to select patients. Might work in gastric, MET high, or should you just look for amplified MET amplified tumors, which are more frequent in gastric cancer than in colorectal cancer, for instance. So it could well be that we will see this class of agents, let's say positive for, let's say, gastric cancer, esophageal cancer, was negative for colorectal cancer. I put more faith into them than into the IGF receptor inhibitors, which kind of tanked about 2 years ago when we had study after study after study completely negative. I believe that the HGF MET system is a better target for our intervention.
So there are a flock of PARP inhibitors out there, and they're being looked at in GI malignancies as well. And David rattled off a number of them, oliparib and ruparib and neratinib.
In real PARP inhibitors after the failure of the initial so-called PARP inhibitors in breast cancer. And I think it ties into the kind of going into subgroups, for instance, of the BRCA2 positive, for instance, pancreas cancer. We have seen some very interesting data, just single agent PARP inhibitors in pancreas cancer with somatic or germline BRCA mutations, which are very intriguing and warrant further investigation.
So there may be some subsets where we're making progress in pancreatic cancer.
We'll see. We'll see.
Right. So then finally, you took us through your algorithm for the management of colorectal cancer, and it's gotten much more interesting now with the understanding of KRAS and NRAS mutations and the various mutations on a variety of different exons, that you can't just look for KRAS exon or exon 2, codon 12 mutations. It's gotten much more complicated.
Yeah, and that's, I think, one of the real success stories of having a large trial with a lot of biospecimen that you get on patients, and then asking, kind of putting questions to these biospecimen and correlating outcome with certain molecular features. And the story was broken more or less by the PRIME study and Amgen study with panitumumab added to FOLFOX. They had a lot of biospecimen, more than 90% of patients with good biospecimen collection. And they could then profile these tumors beyond what we normally do, KRAS exon 2, codon 12, 13 mutations, and identify another 17% of patients with mutations in KRAS exon 3 and 4, and NRAS exon 2 and 3, and not 4, but was tested too. So these 17% of patients actually, when they received panitumumab in the context of FOLFOX, they did not only have no effect, no benefit, but potentially a detrimental effect. And this goes into patient safety. So do we now, and I actually strongly believe we need to expand our RAS testing before we treat patients with EGF receptor antibodies. Now the PRIME data, panitumumab, we're conducting in context of FOLFOX. There's emerging data from irinotecan-based studies, the PICCOLO study with panitumumab, second-line trial in the UK, and also the FIRE study, first-line head-to-head bevacizumab, cetuximab, where it seems to be, with small patient numbers, of course, that the patients with the additional RAS mutations, which we do not identify with our standard KRAS test, might have a detrimental effect in progression-free survival when cetuximab is added to irinotecan FOLFIRI compared to bevacizumab.
So in the FIRE trial was really interesting, and now, from what I understand, Alan Vanook's CALGB trial is going to be presented at ASCO.
Yeah, 8405, the CALGB SWOG trial, has an adequate number of patients to answer the question of overall survival, 1,250 patients.
Right.
Really valuable for this comparison, whereas FIRE3 was powered for response rate, as a phase 3 trial, investigator-assessed response rate. And the finding of overall survival difference was only kind of a secondary endpoint. It's, whenever we see overall survival differences, you can't ignore them. I mean, I think this is a very important point. That's why I understand why a lot of attention is kind of put on FIRE3. But from a statistical perspective, you have to really see, the primary endpoint was negative. An important secondary endpoint, progression-free survival, was completely negative. I mean, in terms of there was no difference. And then you see the split on overall survival, we're all puzzled.
Right.
Because we have seen similar data, no difference in PFS, but difference in OS, perhaps for immunotherapy trials, but not for anything we've ever seen in colorectal cancer outside of immunotherapy. So it will be interesting to see the data of 8405, which has a similar design, cetuximab versus bevacizumab in first line, FOLFOX or FOLFIRI as a kind of chemotherapy backbone. And we will see the data. It's a full abstract. It's not a late breaker. So about a week or two before ASCO, everyone can look it up.
Everyone look at it, yeah. Well, it's going to be really interesting, hopefully in a few years, when we understand a lot more about the biology of these cancers and we can explain some of these differences in why curves separate at various times and which are those patients who, if they last long enough, begin to get a prolonged effect.
Yeah. If I had to put my best guess to that, is I could see that we will identify a subgroup of patients, perhaps characterized clearly by all RAS wild type, perhaps PIK3CA wild type, P10 expression levels maintained, high ligand expression levels, of the EGF receptor system. So we could probably refine a patient population that really benefits from EGF receptor antibodies first line. And this is great because we're going away from empiric, one size fits all, to a more refined patient population. In the EGF receptor antibodies, probably more like not in terms of a positive biomarker. When you have this, you need to use EGF receptor antibodies, but excluding patients who have no benefit from the treatment.
No benefit and can avoid the toxicity.
Avoid toxicities, and again, avoid potential detrimental effects.
Yeah, absolutely. Axel, thank you so much.
Yeah.
This has been really interesting. It was a great GI session this afternoon. I enjoyed it. I think everyone in the packed room really enjoyed it too. So thanks for spending some time and going over it with us.
It's a great meeting, and you can see the feedback you get from the attendees. I mean, I can only encourage everyone to come next year because it is a great meeting.
Yeah,
a lot of time
questions
to interact with the faculty, a lot of questions, clinical cases discussed. So I think it's really worthwhile coming here.
Enjoyable meeting. Thanks so much. Thanks to all of you for watching Expert Perspectives from the 20th Annual NOCR meeting. I hope you'll be able to watch all of these segments from the meeting. Thanks again.